Hello everyone, welcome into today's lecture. We're going to be talking today about heart blocks. This PowerPoint was made by Oscar and I'm going to be narrating it. I'm Dr. Yasa, EMS fellow. This lecture here, we're going to be talking about heart blocks and pacing. This also I found heart blocks to be one of the tough subjects that we kind of deal with in the field. It's a lot of times tough to recognize and tough to manage as well. So we're going to be talking in this lecture today about the cardiac conduction system, identifying the major types of heart blocks. We're going to be interpreting some rhythms and having some examples. We're going to be talking about management of stable versus unstable bradycardia and also pacing, what constitutes a false capture and what is constituted to be good capture, successful pacing, and how to manage these kind of scenarios in the field. So without further ado, I'm going to start first with the conduction system. So as we know, the electrical conduction starts from the SA node, travels down to the AV node, and then the bundle of His, bundle branches, and then Purkinje fibers. So if you're talking about the left bundle branch block or right bundle branch block, it will be at the level of the bundle branches here, so lower down. The PR interval is the time from the atria depolarizing, which will be the P wave, to the ventricular QRS complex. So if you're talking about PR interval increasing or changing, prolonging, that we're talking about specifically from the time of the P wave to the QRS complex. So the block usually occurs when there is a signal that is delayed, interrupted, and will usually cause some form of bradycardia below 50 or below 60. And causes of that will be ischemia, scar tissue, medication. Specifically, we see that in medication overdoses, like beta blockers or calcium channel blockers, digoxin, vagal tone, if we're talking about vasovagal syncope, for example. And then aging, sometimes we don't have really a reason why that happens, but just due to the aging process, there will be some changes to the electrical conduction system of the heart. So bradycardia in general is above 60. We really start to worry about it when it goes down below 50. A lot of people will have some bradycardia normally. That's how they were. They were born with this, or they were like athletes as well. So with that, we want to develop a rhythm that every time we check the same thing so we don't miss a block. So we'll check first for regularity, P to QRS relationship, any sort of drop beats, the PR interval, and the QRS width. And then we want to be aggressive with our treatment if there is any signs of instability. So systolic blood pressure less than 90, any signs of altered mental status, shock. So we want to go ahead and start treating if we see bradycardia on our heart rate, and we don't want to really delay to obtain a 12 lead. We're definitely going to want to get a 12 lead EKG to see what's the underlying cause, but be aggressive with the treatment when there is bradycardia and signs of instability or shock. So the first type will be a first degree AV block. So there is a PR interval of above 0.2 seconds, and it is constant. So there are no drop beats, and it is the same P to PR interval in every lead that we have. Usually benign, but sometimes can become symptomatic. And by symptomatic means that the patient is having like dizziness, altered mental status, having weakness. All of these signs are going to be that the patient is symptomatic from that first degree AV block. So for the treatment, we're going to start first with the 250 cc of normal saline, try to maintain that SBP above 90. And if that fails, then we can try atropine next, so 1 milligram IV, or we can even use atropine and fluid at the same time too. And then we can repeat the atropine up to 3 times, so 3 doses, so max of 3 milligrams. I want to give it about 3 minutes to see some type of effect before repeating. Atropine is good for first and second degree type 1 AV blocks, it doesn't usually work on third degree or second degree type 2, what we call MOBITS 2. It usually wouldn't work on those. And I've seen like some people that have had first degree AV block for most of their life, and then at some point in their time they become symptomatic from that, and they can actually get a pacemaker for a first degree AV block if they have symptoms from it. So here's an example of first degree AV block. As you can see here, the P wave QRS complex, and we can see the distance here. It is prolonged between the P wave and the QRS complex, but it is the same distance everywhere, and it's not changing. And there are no dropped QRS complexes. So before every QRS, there is a P wave, and there aren't P waves that are not conducted. So this will be a first degree. Then we can move to the second degree AV block. So second degree type 1, or we call it Winky-Bach, sometimes call it MOBITS 1. So this will be a progressive PR lengthening until you get a dropped QRS. Longer drop, or later gone, or kind of like the mnemonics for that for Winky-Bach. So usually they will be bradycardic, and the BP might be stable, might be unstable. We can try, atropine for that every 3 minutes if they are showing any signs of instability. And then if it's ineffective, then we can go to transcutaneous pacing. If we have any sort of unsuccessful pacing for any reason, then we can try a push dose epi. And if there is persistent hypotension even with the epi, we can move to norepi to try to maintain that blood pressure as well. So an example here of a Winky-Bach or second degree type 1. So as you can see here, the PR interval here, and then compare it to this one. So you see it starts to lengthen, and then lengthens more, and then a drop. So this is P wave, there's no QRS, and then we see another P wave here, and then the cycle restarts again. I'll consider it normal here, a little bit prolonged, more prolonged, and then a drop. Then we move to the second degree type 2 now. So this is MOBITS 2. And this will be considered one of the ones that the atropine is not gonna work, and more of the worrisome one now. So the second degree type 2 and third degree heart block, usually when you see a lot of instability with that patient, and they usually will need a pacemaker if they have that. So the PR now is constant, but we have dropped QRS complexes. So you can have 2-to-1 or 3-to-1. And by 2-to-1, meaning that there will be 2 complexes that will be conducted, and then you will have a drop. Or 3 complexes that are conducted, and then you have a drop. So a lot of times, though, they will also progress to a complete heart block. We don't know when. We don't know that when it's going to happen. It can happen in the field, or it might happen later as well. So usually those will also be a little bit older, but I wouldn't pay any attention to like the age with those. Like age is not really what tells us what kind of type, but usually you will see those with older patients. And like I said, usually they will be unstable as well. You want to start if they're having symptoms, they're unstable, altered. I want to start pacing, and when you see that bradycardia with that heart rate and that unstable BP, so we're gonna start pacing. Want to get an IV established right away, and then like I said, atropine usually wouldn't work in that case. So pacing is uncomfortable for the patient, causes pain because you're constantly delivering electric shock to them. So we can try to give them some pain medication. I will hold off until we get some improvement in the blood pressure with the pain medication, because any pain medication that you give with that blood pressure can cause even further hypotension as well. If we are having failure to capture, we can move then to push dose epi. And that persistent hypotension, even with the push dose epi and trial of transcutaneous spacing, we can augment that with some norepi and fluids as needed as well. So here's an example of a second degree type 2. So we see here that this PR interval is normal. It's not prolonging from this to this one here, and then a drop. So the QRS dropped, and you can have multiple drops as well. And then you can have normal, 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 and that drop. So that is a kind of like an example of a type 2 AV block. Mobitz type 2, I'm sorry. Third degree, or we'll call it complete AV block. So this is where the atria and the ventricles are kind of like not talking to each other. There's no relationship between them. The atria is beating at a certain pace and the ventricle is beating at a different pace, and there's no communication with them. And usually you'll have some sort of an escape rhythm, meaning that a rhythm that is initiated more from the ventricular side, so it's a lot slower, and it could be juncture or ventricular. The ventricular is usually between 20 to 40 beats, and the juncture will be 40 to 60 beats. And this is basically that escape rhythm is what's keeping them alive. Usually it will be like pretty unstable as well. Although I've seen in some rare cases they are actually stable with a complete AV block, but this is extremely rare. Most of the time you're gonna have unstable patient. So kind of like the same thing. We wanna start pacing right away, and we're gonna be talking more in another slide about like the mechanics of pacing and what we need to do. But you're gonna do pacing, you're gonna do trial of some IV fluids, get an IV, and then augment your therapy as we talked about before, and definitely transferring to a PCI capable facility. So kind of an example of a third degree AV block. So we can see here that the ventricular, so the QRS complexes are normal width, and they are moving at the same rate together. So the QRS complexes, the distance between the QRSs is the same, it's not changing. And then the P waves are also the same here and not changing. And sometimes you might have an underlying sinus arrhythmia. So the QRS complexes might not be 100%. If you get an actual ruler, they might not be 100% the same. There will be very, very, very small variation between them, but this is still considered a third degree heart block. So the P waves will be marching together, the QRS complexes marching together, but there's no communication between them. So this is kind of a table that summarizes the stuff that we talked about. So first degree, P2P is regular, PR intervals regular, and then you're gonna have an increase in the PR interval, and you wouldn't have any drop beats. When we're talking about the second degree, Winky-Bach, longer drop. So the P2P are regular, the PR intervals are irregular, meaning that they are changing. So it will usually be increase, and then drop. Type 2, P2P still regular, the PR interval are regular, and then we're gonna be seeing a 2-to-1 or 3-to-1 or even 4-to-1 conduction, where we have P QRS, and then P dropped QRS, and then P QRS, P QRS. And then third degree, the P2P are regular, the PR are regular, so the QRSs are marching together at about the same rate, the Ps are marching together about the same rate, but there's no communication between the two. So treatment summary, first degree AV block, gonna monitor, get a 12 lead, any signs of instability, You can give atropine. Atropine is not working. Can move to transcutaneous spacing. Second degree type 1 or Winkebuck, that will respond to atropine. Same thing, atropine not working, transcutaneous spacing is not working. We can do now push dose epi, not working. We can go to augmentable norepi. Second degree type 2. And third degree, now you're talking about most of the time they're going to be unstable. So we want to be thinking about pacing them, transcutaneous spacing, and same thing. If it's not working, we're going to be doing epi and augmenting with norepi if the epi is not working. Norepi doesn't usually affect the heart rate. It's more for treating the blood pressure. It's a peripheral vasoconstrictor. Epi, on the other hand, is both a peripheral vasoconstrictor and increases the conduction and contractility of the heart. So that's why we want to use epi first before trying norepi. So now we're going to move on to pacing. So pacing, we're going to start at a rate of 70, and we can increase that once we have capture. If we're still not getting systolic blood pressure above 90, we want to titrate up that rate to a max of 100. If you're not getting capture though, you can increase the electricity. So the milliamps, we can increase it by 10 to get capture. So we can try, and titrate it up by 5 or 10 to verify capture. So capture includes two things, mechanical and electrical. So I'm going to give you some examples of some electrical capturing and failure of electrical capturing, but you also need to have mechanical. Mechanical, that means that the pulse that you feel matches what you set the rate on for on the machine. So if you set a rate of 70, you should be feeling a pulse of 70. It is very painful procedure, so we can give sedation when we have an acceptable blood pressure. That would be fentanyl or ketamine. You can also try giving them some fluids as well. If we're getting no capture, then the push dose epi, and we talked about previously about how to make a push dose epi. So we're gonna be giving 1 cc every 1 to 2 minutes. And then if still hypotensive, we can go to the norepi, and remember this is just peripherally, so we're just going to be treating the peripheral blood pressure here with the norepi. It's not going to be really affecting the heart rate. So let's go over here. This is a instructional video made by Stryker that makes our life packs, talking about transcutaneous spacing.
The LifePak 15 monitored defibrillator can be used for either demand or non-demand pacing. Demand pacing is used for most patients, so that's what we'll show here. First of all, before you start pacing someone, always consider the need for patient analgesia or sedation. Okay, connect the ECG leads to the patient. You need to do this for demand pacing, so the pacemaker can see the patient's own beats and deliver pacing pulses only when needed. Also, although the quick combo electrodes can be used both to monitor ECG and for pacing, they can't do both at the same time. So, here we go. We have the ECG leads on and lead 2 is displayed. Now we'll place the therapy electrodes. We'll use anterior-posterior here. You can use either the anterior-lateral or anterior-posterior position. Prep the skin as we showed you in the ECG monitoring section. Place this electrode with the heart over the left precordium, just below the nipple. It's important to put the electrode with the heart here rather than on the back, because if the electrodes are reversed, it might require a higher current to achieve capture. Place the other electrode on the patient's back, in the infrascapular area, like this. Be careful to keep adequate separation between the ECG electrodes and the therapy electrodes to minimize artifact on the ECG. Press pacer. You should see sense markers on each QRS, like these. If you don't see sense markers, or they're on the T-wave, adjust the ECG size or select another lead until you do see sense markers. Now, press rate. Press the up or down arrows to get the rate you need. Press the current up arrow repeatedly to increase the pacing current. Now you can see these pace markers, indicating that pacing current is being delivered. You should notice the patient beginning to twitch. Increase the current until you see electrical capture. You'll have electrical capture when each pace marker is followed by a wide QRS and a T wave, like this. It's important to be aware that the average current needed for capture is between 50 and 100 milliamps. The final step is to ensure that you also have mechanical capture. Palpate the patient's pulse and obtain a blood pressure. Pulse oximetry may also be useful. Observe the patient continuously while actively pacing. The patient's response to pacing therapy may change over time. If you need to check the patient's underlying rhythm, press and hold pause to temporarily reduce the pacing rate. Release the button to resume pacing at the set rate. To stop pacing, press pacer. A few more things. During pacing, you always see dashes up here instead of a heart rate, and the heart rate alarms are disabled. It's important to frequently assess the patient for mechanical capture. If an ECG lead comes off, pacing switches to non-demand, and the monitor shows a dashed line for the ECG. This means the pacemaker paces 100% at the set rate, regardless of the patient's underlying rhythm. To re-establish demand pacing, reattach the ECG electrode. If you're increasing the current, but the patient is not twitching, check the patient's heart rate. Remember that the pacing rate needs to be set higher than the patient's own rate for pacing current to be delivered. If you're pacing and the patient needs to be defibrillated, press charge. Pacing stops automatically. Proceed with defibrillation as described in the manual defibrillation section. And that's it for pacing.
All right. So I have an example here of capturing, and I believe that capturing is usually the most problematic thing to do in the field. So it is very easily that you can miss that is it actually pacing or not. You're usually able to figure it out if you check the pulse and pulse is not matching. But here's a kind of an example of pacing, then we'll see like if it's capturing or not. So as you can see here, there's no pacer spikes. EKG looks about regularly the same. Here we're still below the threshold, so we're not getting some capturing. So you see the spike here and a spike there, spike here, but it's not before where we want to see. So this pacer spike should be right before the QRS complex, not on top of it, not after the QRS, but it should be before the QRS. And this is an example of true capturing. So you see it's before the QRS, and the rhythm now, it almost looks like it's a STEMI. So you're gonna have this wide QRS complex, broad and wide T wave that is actually, we can say there is like possibly SC elevation there. So this is considered now capturing. And if you are doing pacing, I would highly recommend that momentarily you pause pacing, check the underlying rhythm, especially if the patient is not awake, because you're now pacing the patient and they might be into cardiac arrest now, and it's very tricky to figure out if that pulses that you're feeling is just from the pacing and the patient is being appropriately paced, or they actually in cardiac arrest and we need to start doing CPR now. So once if we're into that situation where we have an altered patient that is not awake, look at the pacing, pause it, check the underlying rhythm, and then continue pacing again. You won't need to change the settings or anything like that when you resume pacing again. Also, other like surrogate markers that you're actually having good capturing and good pacing is that patient color will improve, your end tidal should improve as well, because now we have more perfusion, so you're gonna have more gas exchange, all of that sort, kind of like surrogate markers for you as well. And definitely be rechecking that blood pressure. So here's another example of false capturing. So you can see here the pacer spikes are on the QRS itself, and now it's haphazard. It's even not every time, and it appears and disappears. So this is definitely false capturing. An example here of true capture, like I was saying, before the QRS, you have this wide QRS, wide T wave that looks almost like a STEMI or a left bundle branch block. So you can have that widened rhythm that usually indicates a true capture. So reviewing some of the reversible causes for bradycardia. So beta blocker overdose, give a glucagon, bicarb, for acidosis, calcium channel blocker, calcium, hyperkalemia. You're gonna have those tall peaked T wave. Usually patients who are dialysis miss their dialysis, bicarb, albuterol, opioid overdose. They can have sometimes even some heart blocks as well. So we're gonna want to treat the heart block, but also treat the opioid overdose with naloxone as well, and then TCA, antidepressant, bicarb for those. So going over some scenarios for practicing 68-year-old male, heart rate 34, BP 80/50. They have loss of consciousness or decreased mental status. You get a complete heart block on your 4 lead and 12 lead fluids. We want to apply pads right away, start transcutaneous pacing, start an IV, and then figure out the underlying rhythm. And if you're not getting any push dose epi, if you're not getting any improvement in the blood pressure, or we're having any problems with capturing, then we're gonna move to push dose epi and definitely transport to a PCI capable facility. Another scenario, 54-year-old female, near syncope, heart rate 46, BP on the soft side. You get an EKG and it's a Winkie-Bach, so 2nd degree type 1. Put the pads on, start an IV line, give atropine and IV fluids. Once the heart rate improved, we don't need to give any more atropine, and monitoring, continually checking the blood pressure en route. So some key points to always remember: following the protocols for bradycardia, try to identify type of heart block as fast as possible, and do not delay treatment for instability to obtain a 12 lead on IV, and try to sedate if the blood pressure allows and you have a more stable blood pressure. And these are some of the references. Thank you so much.